and let us go on with the session. How to approach a large thrombus burden in the context of ST elevation myocardial infarction, a case-based approach. We will go through a few points like a brief introduction to thrombus burden in acute myocardial infarction, the consequences of thrombus burden, the various strategies available to tackle the problem of a large thrombus burden, the importance of prevention of complications, the limited treatment recommendations and guidelines, mainly due to mixed or paucity of convincing data. You don't have like class of recommendation, one kind of guidelines in this particular area because of the paucity of convincing information in the literature. And we will briefly go through 5 case examples to highlight salient points. Each case will have something to help us learn about thrombus. And I will also, to break the monotony, I have taken the liberty to include a few illustrative ECGs of interest in a few of these cases, which really mattered to the treatment in these patients. Primary PCI, as we all know, has revolutionized the treatment for ST elevation MI. It offers rapid recanalization of the epicardial infarct-related artery, reduces infarct size, and it also substantially reduces adverse clinical endpoints. A large proportion of patients have suboptimal myocardial tissue perfusion. We might open up the epicardial coronary artery, but there may be suboptimal tissue perfusion. Finally, it is the tissue perfusion which really matters. And why this happens is because of the large thrombus burden, and myocardial infarction itself is a prothrombotic milieu. And as I repeat again, there are no strong recommendations in the context of large thrombus burden in the guidelines. Thrombus has been graded as 0 to 5, depending on whether there is no thrombus, that is grade 0, or whether there is a complete thrombotic occlusion of the vessel, that is 5. And depending on the length of the thrombus in relation to the diameter of the artery, it has been variably graded as 1, 2, 3, 4. What are the problems associated with the large thrombus burden? It can cause either distal embolization or it can cause retrograde embolization. What do we mean by distal embolization? It causes reocclusion of the infarct-related vessel, the branches, the distal territories beyond the stenosis or beyond the occlusion. This can be either spontaneous or it can be secondary to instrumentation like wiring, ballooning, stenting, so on and so forth. And this can result in reocclusion. It can result in devastating complications like slow flow, no reflow, primarily due to obstruction at the microvascular bed. That is why no amount of aspiration, etc. works when there is no flow. And this can have very bad consequences. Some of the patients fortunately tolerate. Some of the patients do very badly, and it even cause death if the territory is very large. Retrograde embolization can be could be to the non-culprit vessels. For example, when you deal with an anterior wall MI, a thrombus can migrate into the circumflex. And that can be very, very detrimental to the patient because it causes ischemia and yet another territory beyond the original myocardial infarction. And it can also embolize into the systemic circulation. It can cause transient ischemic attacks. It can even cause a full-blown stroke. How do we assess adequate distal microvascular perfusion? We look at the TIMI flow grade, myocardial blushed grade, and ST segment resolution on the ECG. These are some of the yardsticks we use to assess the extent of distal microvascular perfusion during primary angioplasty. What are the strategies to tackle thrombus burden and embolization? It can be either pharmacological or it can be mechanical. In pharmacological, we have the very potent antiplatelet drugs, GP2B3A inhibitors, which can be given intravenously or intracoronary. Of course, the enthusiasm on these molecules has considerably come down compared to what it used to be 20 years back. However, you can still reserve it for the deserving patients with very large thrombus burden when you're running out of options. It cannot be routinely used, may be considered in large thrombus burden, no flow, slow flow, etc. Of course, not to forget adequate anticoagulation, which is very important. Intracoronary thrombolytics also have a role, particularly drugs like alteplase, which have some evidence in the literature, though not very robust. Mechanical solutions can be thrombectomy or thrombus aspiration. All of us are very familiar with thrombus aspiration using the diver catheter or the export catheter, which we use routinely in practice. Again, the recommendations now is lesser. Previously, we felt that it is a panacea of all thrombotic lesions. Now, with all the available literature and with large studies, we find that we can get away without thrombus aspiration in a vast majority of patients. Stenting strategies also are very important when it comes to thrombus burden. We can resort to direct stenting. We can do deferred stenting. do a balloon dilatation, resume flow, shift the patient back to the ICU, give prolonged glycoprotein 2B 3A inhibitors for about 24 to 48 hours, bring the patient later and the flow is better, you can always do stenting. That is called deferred stenting. Again, not recommended due to positive data in the guidelines, but we find it extremely useful in our practice. The M-Guard stent was out of favor due to high rate of stent dislodgement. And this is the meta-analysis of thrombus aspiration. You should understand that thrombus aspiration in the most recent meta-analysis in 2017, as you can see here, it is not statistically significant in terms of no thrombus aspiration. So we have come to learn the Thrombus trial in 2008 was one robust trial which included about 1100 patients, and that showed significant benefit, and there was a lot of enthusiasm in using thrombus aspiration in every myocardial infarction. But if you look at the trials, the large trials in 2015 and 14, the TASTE trial and the TOTAL trial, which recruited about 10,000 patients and 7,000 odd patients, the data was not very significant. And post these two trials, the meta-analysis has definitely shown that routine thrombus aspiration is not recommended in the context of ST elevation myocardial infarction, though you can reserve it for those patients who have extensive thrombus burden. That is why the guidelines also from 2A became 2B and then became 3, etc. as time went by. So if you look at the overall algorithmic approach before we go to the cases, the minute you pass the guide wire and you find that there is thrombus grade is only 0 to 2, not a very massive thrombus burden, you can resort to direct stenting or balloon and stenting as the case may be. So wire passage, reasonable antegrade flow, less thrombus burden, you can proceed with stenting. You can even do a direct stenting provided the lesion is not very complex and there are no concerns about taking the stent to the destination. To the contrary, after passing the guide wire, if there is a grade 3 to 5 thrombus, so there is a lot of thrombus burden. Now let us see if the patient is ischemic. And if you can establish some flow by doing some balloon dilatation, etc., you can do what is called a protracted course of glycoprotein antagonists, defer the stenting to a later date, maybe 1 day or 2 days later. You find the situation is much better because at the end of the day, you need tissue perfusion. You should not be very anxious about stenting in the first day itself. You can always stent it a couple of days later, bringing the patient back to the cath lab. To the contrary, you pass the guide wire, there is extensive thrombus burden, but the patient has significant ischemia and the flow is not good. You have no other choice but to proceed with angioplasty in the same sitting. That is when there is some role for thrombus aspiration in reserved cases. And then after, if you have a good flow after thrombus aspiration and balloon dilatation, you can do stenting. And not to forget the adjuvant role of glycoprotein antagonists and adequate oral dual antiplatelets and antiplatelets and anticoagulation is the pharmacological sheet anchor in the treatment of this particular problem. Now, moving on to the cases. The first case is a 42-year-old male, a smoker, a diabetic, who presented with an acute inferior wall ST elevation myocardial infarction. The left system was essentially normal, as you can see here. The right system, this was the first shot after doing the angiogram. One may even think it is a guide catheter dissection because it looks like a spiraling thing. But you can see some filling defects in the mid RCA there. This is just a frozen still frame of that. So we just wired this vessel with much ease. We wired. This was done in the year 2012. We did multiple runs of thrombus aspiration, as you can see here. And after a few runs, you see that the flow has improved. Then there was distal embolization of the thrombus. That itself means that you are not dealing with dissection. The very fact that the proximal has cleared and the distal is occluded means the thrombus has migrated more distally. This is what is called distal embolization. We did one more run of this thrombus aspiration. And the flow gradually improved to the distal vessels. And that is the final after multiple runs of thrombus aspiration. We take multiple angles to make sure that it was not a dissection in the first place. This patient is under my follow-up for the last 8 years and he's absolutely doing fine with negative treadmills every year. This is the final picture. So this is a case which demonstrates that standalone thrombus aspiration can be a choice when there is plaque erosion rather than plaque rupture, which was not shown in this case at that point in time. But in hindsight, we know that it was a probable plaque erosion more than a plaque rupture. In the days of imaging using OCT, the plaque characteristics can be understood better. And there is now emerging evidence that when somebody has plaque erosion, you can do predominantly antithrombotic strategies like aspiration, balloon dilatation, local thrombolytic delivery, and avoid stenting with very good results in the long term. So this was a case which shows that standalone thrombus aspiration has a role. Moving on to case 2, a 63-year-old male, a diabetic hypertensive, acute inferior wall ST elevation again. This is the ECG. There was a little prolonged PR interval, 230 milliseconds. As you can see here, there is some ST elevation in the inferior leads, some ST depression in lead 1, AVL and V6. And the left system had some disease, but smaller vessels with reasonable flow, which was not the problem in this patient. And this was the right coronary artery, which was totally occluded. So we wired this vessel. As I told you in that original algorithm, which was proposed by a British group, if you see here, the minute we wired this vessel, there is significant improvement in the distal filling of the RCA and its branches. That itself means that the thrombus burden is not very extensive. You don't have to resort to thrombus aspiration, glycoprotein antagonists, local thrombolytics, so on and so forth in this particular patient. Passage of the wire, resumption of antegrade flow is a very good sign. And true to what we believed, we dilated this lesion with a balloon. There was very good antegrade flow. We stented it, post-dilated it, and we had reasonable good result at the end of the procedure. And coming back to the ECG, the next day, my fellow on duty said this patient has developed a paroxysmal supraventricular tachycardia. He doesn't see P waves, and he even felt that it is a short RP tachycardia. That is not the point of interest in this case. I just wanted to say that if you look at the rhythm strip, there appears to be no P in front of the QRS, but you should understand that this is actually a P, a sharp thing very close to the QRS complex. This P is actually conducted to the next QRS. This P is conducted to the next QRS complex. So there is sinus tachycardia with so grossly prolonged PR interval that the P is closer to the preceding QRS than to the next QRS. So I have animated with arrows to show the P waves for you. And the next day you can see 2:1 AV conduction defect here. This P is conducted, this P is not conducted. This is the typical evolutionary pattern of AV conduction defect in the context of anterior wall MI, particularly so if you create recanalization of the vessel with good perfusion. The patient needed temporary pacing for a while. Then as you can see here, there is group beating. This is Wenck back pattern. And then this patient again started recovering 1:1 conduction with a first degree AV block. So this case highlights the reasonable antegrade flow after wire crossing as a sign of low thrombus burden, and that takes away the need and the headache for aspiration and adjuvant therapy, which was amply demonstrated in this particular case example. Moving on to case 3, a case of recent inferior wall MI presented to our institution 2 days after the MI. He did not have post-MI angina. He had mild basal inferior hypokinesia. Overall, the LV function and the RV function was good, and this is the diagnostic angiogram. The left system, there was an occluded distal circumflex and a late filling obtuse marginal branch. The LED had a non-flow limiting disease in the proximal. I want you to understand that there is a good collateralization of the RCA here. So it's a protected RCA. And the RCA is occluded here. And you can see here, there is a lot of filling defect in the mid-distal RCA that you can see here. I have kept a still film for you to appreciate the filling defect in this particular view. This is the lateral projection. Again, showing a large filling defect in the mid RCA. Again, I have a frozen film for you. That is the thrombus in the mid RCA. That is the AP cranial view, all showing the same thing. You can see a nice big filling defect extending at least 3 to 4 times the diameter of the vessel. That means it is a grade 4 thrombus. That is the thrombus that you see in the still film of this particular view. So this patient is stable. He has come to us 2 days after the MI. He doesn't have much of pain. The distal RC and PD are collateralized by the left coronary artery. There is extensive thrombus burden, maybe TIMI grade 4 thrombus. The risk of distal embolization to us, what is collateralized may go off if this thrombus migrates to the PDA. What the left system supports also we may lose if we are in a hurry-burry to do this case. So this patient was shifted back to the ICU. We gave a 1-day infusion of tirofiban. And the patient was brought back to the cath lab the very next day, and you see what happens. you see that there is extensive clearance of the distal thrombus. We are only left with the proximal disease. So this is a much better situation to deal with than what was 24 hours back after the 24-hour infusion of tirofiban. So we dilated, we stented it, and post dilated it, and this is the final outcome. You have just a very good distal perfusion. If you had been a haste and did the case on the first day, you probably could have got away by aspiration, etc. But this is a much better strategy. This is what is called the deferred stenting strategy. So this case tells us about what is this deferred stenting strategy. Moving on to case 4, a 35-year-old smoker, diabetic, lot of inferior myocardial infarctions I'm showing. Thrombus can happen in the other vessels as well, but this cluster of patients happen to have inferior MI. Most of these patients I dealt with in the last 4 weeks or so. You can look at the ECG. This patient came with some vague chest pain, and there is some ST elevation in the inferior leads that you can see here. And the right-sided leads showed probably minimal ST elevation in the right-sided leads, suggestive of an added component of RV infarction. And the left system again had some ectasia with no flow limitation. And look at the thrombus burden in the RCA. Extensive thrombus burden in this RCA. Ectasia, large vessels, ectatic vessels, thrombus. Dr. Matthew has taught me when I was with him in 1998. Always be aware of the vessels may be very large, but they will give you a lot of headache. Thrombus in a large ectatic coronary artery is substrate for all kinds of problems. You should not think it is a light case. It's going to be a difficult case. Anyway, this patient was sick, and so he had very low blood pressures at that time. So we had no other choice but to wire this vessel. We are doing some multiple runs of thrombus aspiration that you can see there. So we could get some kind of perfusion into the distal vessels, but much less satisfactory than what you would want to. Then we gave local thrombolytic with tenecteplase in the intracoronary dose with the microcatheter kept in the region of the thrombus itself. Despite all measures, nearly 1 hour or 1.5 hours of struggle, we could not establish good flow. But fortunately, the patient hemodynamically became a little better. So this was a case of extensive thrombus burden, which was very resistant to all that we did. Multiple thrombus aspirations, local delivery of tenecteplase into the thrombus using a microcatheter, repeat thrombus aspiration, some balloon dilatations also we did. I didn't show the sequence in the interest of time, but we just could not overcome this thrombus burden. We could not resume good antegrade flow in this case. And this was the ECG. As expected, the ST elevation persists. I already told you, persistence of ST elevation is a sign that there is no good myocardial tissue level perfusion. We are not interested only in the epicardial coronary artery. We are also interested in tissue perfusion. And as was the angiogram showing you, there is resistant ST elevation in the inferior leads. And you can see again. And again, if you see this, there is a small P wave which is seen after the T wave here. So this patient developed a 2:1 AV block the next day, which is very much expected in the angioplasty, which did not work in the context of a dominant right coronary occlusion. AV conduction disturbances you should be wary of. You should look for them in the ECG very carefully, and you should act accordingly. And this patient again started pacing. We put a temporary at the time of the index procedure itself, and he started getting intermittently paced, as you can see here. And this was the next day. You see multiple non-conducted P waves and pacing. So he has progressed into a complete AV block on day 2. This is when you should understand that this patient has an RV MI. In RV myocardial infarction, AV sequence, AV synchrony becomes very crucial for us. Unlike an anterior MI, an RV is a chamber which needs good filling. It's a preload dependent chamber, and the atrial contribution to RV filling is very essential, and that is lost in complete AV block. And that is how these patients don't tolerate this complete AV block, and they don't do well with only ventricular pacing. You see here, whenever the patient needs ventricular pacing, the BP falls from 110 to 85. That is because this patient on echo started developing a dilated RV with moderate degree of RV dysfunction. RV dysfunction patients do not tolerate complete AV block, and ventricle alone pacing, which is often the strategy that we use during primary angioplasty, does not work in this circumstance. So this patient was This patient was in this problem on the fourth day. He needed to be ambulated, and we knew very well that most of the time these AV blocks will always recover. So what we did new in this patient was we took two dual access in the jugular vein. We put permanent leads in the right atrial appendage and in the RV, like you do a permanent dual chamber pacemaker. These are permanent leads, and they are connected to a refurbished permanent pacemaker, which is kept outside the chest. It is not an implanted pacemaker, but you get the benefit of AV synchrony. You can mobilize this patient out of the CCU, and you have your own sweet time. The lead does not displace, the lead does not perforate. You don't have problems like deep vein thrombosis with femoral venous leads. So this gives you a lot of advantage. That's why I wanted to show this in this particular case scenario. And this patient developed atrial, there is the resumption of AV synchrony you can see here. For every P, there is a paced QRS complex. And true to what we expected, the patient's own AV conduction recovered. You can see P and the native QRS complex. This is what we expected, usually by 1 week's time, this AV block. But this patient needed this AV sequential temporary pacing because he was not tolerating ventricular pacing. He was developing significant hypotension, needing dopamine, etc. So this trick of doing this transvenous permanent lead temporary AV sequential pacemaker helped in this case. So this case highlights resistant thrombus despite systemic glycoprotein antagonists, despite intracoronary intrathrombus thrombolytic through a microcatheter, repeat balloon dilatations, etc. RVMI and the importance of restoring AV synchrony, especially with borderline hemodynamics. That was the highlight of this case. The last case I want to show you, again, as Dr. Matthews said in last week's talk, it's always good to share complications and mishaps which happens in your experience. All of us have unexpected mishaps in our cath lab. It's always good to share so that we learn from each other's experience so that these problems can be minimized in future. They cannot be eliminated completely. At least we learn from others' experience so that we don't make mistakes. If it is a mistake, we don't make mistakes. If it is unavoidable, yes, fine. A 56-year-old male, 65 kilograms, which is very relevant to this case. Smoker, diabetic, acute inferior MI again. Significantly symptomatic when he presented to in the emergency room. Loading dose of ticagrelor followed by the usual conventional dose, aspirin in loading dose. The patient was wheeled into the cath lab. 7,500 units of unfractionated heparin was given. This is the left system. You see that there is significant disease of the osteal, post-osteal or osteal LAD, post-osteal circumflex, a major OM branch. That's the epicranial view, significant disease. If this patient was to come to me with a STEMI or in stable situation, I would have probably counseled him for a bypass surgery. But this patient was very sick with severe pain. That is how you fall into the trap. So you open up the infarct-related vessel and you're committed to doing a completion angioplasty to the left system. Not that it cannot be done. We have done such cases in the past as well with very good results acutely as well as in the long term. These are all doable cases, but the alternate option of surgery should be considered. But nevertheless, as I told you already, we had to do the angioplasty to the right coronary artery. And this was the right coronary artery here. This was after starting glycoprotein antagonist. There was some antegrade flow. The vessel was wired. 2 stents, overlapping stents were put in the RCA. And this was the final result. It was a satisfactory result in the right coronary artery. So we decided to stage the other complex angioplasty to a later date. So we brought him a couple of days later to the cath lab for the next procedure. Again, this patient was already pre-treated with dual antiplatelets. We gave him 7,500 units of unfractionated heparin. He was only 65 kilos in weight. So the heparin dose was adequate. So we repeated the views, which I've already shown you. So we wired the circumflex and the LAD. We dealt with the circumflex first so that we can have a peaceful intervention on the LAD. We put a long stent right from immediately after the ostium, covering both the lesions. And we stented it. We post-dilated with reasonable result in the circumflex. Now we moved on to the left anterior descending artery. We wired the diagonal, retaining the circumflex wire because we thought that we are going to stent it from the ostium of the LAD. Should there be a need to do something again to the ostium of the circumflex, let the wire be in the circumflex. So we have now 3 wires, one in the circumflex, one in the diagonal, and one in the LAD. We dilated the diagonal lesion. We dilated the LAD lesion. We wanted to do a mini crush stenting of the diagonal and the LAD. So we have parked the stent in the LAD and we are positioning it in the ostium of the diagonal. We deployed it, keeping the LAD stent there. And after removing the wire and the balloon from the circumflex, we deployed the stent, keeping it as close to the ostium of the LAD as possible. And then we wired the diagonal once again, did a sequential, and finally a kiss. We were about to dilate the proximal LAD. That is when this patient had excruciating chest pain, significant fall in the blood pressure, steep ST elevation in the monitor leads. And you can see there is an extensive thrombus in the left main coronary artery that you can see here. He became acutely sick. We had to call the anesthetist. We had to intubate him. We did some dilatation of the left main, thinking that we couldn't aspirate any thrombus. There was dampening of pressures in the guiding catheter, which is why I believe that it's a possible guide catheter thrombus, a prolonged procedure. And finally, this patient could not be salvaged. So it's probably a case of a possible guide catheter thrombosis, which proved disastrous in this case. 90 minutes of procedural time, multiple guide wires with longer dwell time in 3 vessels, multiple balloon exchanges, 3 stents. ACT unfortunately was not checked intra-procedure because it was only 90 minutes and we thought it is a usual case. Recent MI, which is the prothrombotic milieu. We don't know whether this patient had a COVID problem. We don't know any of these things. So all these things added, and we presume it is a guide catheter thrombosis, and this patient could not be salvaged. So I'll conclude by saying that thrombus is an issue when we deal with ST elevation myocardial infarction. Many a time we get away without serious issues. In a proportion of patients, the consequences can be deleterious, with compromise of LV function, cardiac arrhythmias, which can be tachycardia, bradycardia, and even death in some patients. The recommendations to treat are not strong in the guidelines. You have to basically do it on a case-to-case basis. Adjuvant treatment options are helpful in select cases with large thrombus burden. These options have to be individualized on the merits of a case. I also showed you 5 case examples to highlight a few salient points as regards thrombus burden in the context of ST elevation MI. The case 1 was a standalone thrombus aspiration, which was probably secondary to a plaque erosion. It looked very ghastly RCA occlusion right from the proximal to distal, but on doing thrombus aspiration, the problem settled very well, and this patient is doing well for 8 long years. Reasonable antegrade flow immediately on wire passage in the second patient is a sign of low thrombus burden. Most of the time, you can proceed with angioplasty like a usual case. Deferred stenting in extensive thrombus burden when there is not much ongoing ischemia, or if you pass a balloon and if you get a reasonable antegrade flow, things are improving, but there is significant residual thrombus burden. You can always take another day. You can take a break, give the patient a glycoprotein antagonist, and then bring the patient in next day. Things could be much better. Your life will be much more easier the next day than was the previous day. And the fourth case taught us that resistant thrombus is always a possibility and an eventuality despite all the available strategies in a given patient. Not because of your fault, it is because of the thrombus being so extensive, particularly in an ectatic large vessel, which is very accommodative with the thrombus. The thrombus can be very recalcitrant, and that gives you a lot of problems. And importance of prevention of guide catheter thrombus, you should always give supplemental doses of heparin. Check the ACT more often when there is multiple wires, multiple balloons, stenting, etc. Keep the ACT on the higher side than on the optimal side that you will accept in another patient with simpler lesions. That was what I learned very badly from the 5th case example. I thank you all for your kind attention, and I once again thank Abbott and Dr. Deepak for considering me as a faculty for this very interesting teaching program meant for the younger colleagues. And again, it's double pleasure. Thank you, Matthew sir, for making me what I am, and I thank you once again.
Sir, you need to unmute yourself, sir.
Wonderful, Natarajan. I'm proud of you. I'm proud to say that you were my fellow at one time. I mean, this is the way people should teach. The last one side, you put everything in the right position, right perspective. You have given the right message. You showed 5 different scenarios how to handle it. I don't think any of us need to add anything more. You have summed up so correctly, so well. I don't think I need to add anything. It was wonderful, Narayan. I'm so
Thank you, sir. Thank you, sir.
and it's great. Only some. I suddenly saw one question from Umeshan. The leads you use for the
Temporary pacing.
early pacing was where the leads, new leads or reused leads?
It is always new leads. You
Okay.
should never, you can always put a refurbished pacemaker outside because it is going to be outside the body. The
Okay.
leads have to be new leads like a permanent pacemaker implantation.
No, this is Umesh must be from Calicut.
Yes.
I saw his question, and only whoever is handling the questions, I request you to keep the questions there for at least another half a minute or so that we can notice the questions and give them the answers. And it's very interesting. We have more than 160 people listening to us, and very, very nice presentation. Wonderful. And I don't think I need to add anything. And only a comment I wanted to make, when there is, I have never seen anywhere using an aspiration catheter increase the complication rate. So even if it doesn't give you adequate benefit scientifically, on the scientific papers we have no statistical evidence proving it. But if you have a doubt, there is nothing wrong in using it. See, whenever all these articles come, you must remember most of these articles are looked upon or pushed by the insurance companies in the Western world. How can we reduce the expenses? The only question the insurance companies have in their mind. So, reducing one device which will cost you $200, it's a huge amount of money saving for them. Whereas we don't look at that our practice that way. So, if you are in doubt, if you think an aspiration can help, following all the guidelines which Narayan explained, if you have to defer it. If you have to plan not to do it. Yes, that's all right. But if you think an aspiration catheter can help, it has never, in my practice, in my life, it has never proved anything adverse. So, nothing wrong in using. Though scientifically you have no proof for that. With that comment, unless somebody else in the faculty has any comments, we move on to the next presentation.
Telnomani has something
Sir,
to say.
can I make a comment, sir?
Yeah, please.
Natarajan, sir, it was excellent presentation. We all enjoyed it. Only thing is, when you put this dual chamber TPI, we have the dual chamber TPI also. No, what is the advantage of putting this permanent thing over that?
You can do it jugular. You can shift the patient out of the cath lab. Putting an atrial lead from the femoral vein is not going to be stable. You can put a ventricular lead through the femoral root, but your atrial lead will misbehave. It will fall off. It doesn't stay there because it is not meant to stay there. Whereas the permanent lead, you can actively fix in the atrial appendage and in the RV, and it does not cause perforation, DVT. Patient can be shifted, and it may even take 2 weeks for the AV conduction to resume. So you can avoid putting a permanent pacemaker. Patients are very happy, and oftentimes, 99 out of 100 times, you can pull out the permanent leads when the AV conduction resumes, like what I showed in that case.
Very good, very nice.
Excellent.
There was another interesting question came up in between and just vanished. Please, whoever is managing the questions, can you put the question back?
Sir, can I read it for you?
Yeah.
So there are a couple of questions. One, the dosage of intracoronary tenecteplase, and secondly, the role of guideliner catheter for resistant thrombus aspiration.
Guideliner catheter, can it be used, Deepak? You must be having more experience.
So we prefer
mother
using,
and child.
Yeah, yes. So we prefer using
Yes.
the child catheter for
That's
distal huge clots that's not amenable for the regular thrombosection catheters, because the child catheter, it's got a straight tip and it's 125 centimeters compared to 100 centimeter of the regular guide catheter. So what we do is we remove the Y connector, we attach a hemostatic valve to the tip of the regular guide catheter, and through the guide catheter over a small balloon inflated distally, we take this child catheter, remove the balloon wire, and then aspirate with the child catheter. But I think the same can be done with the guideliner catheter also, may not be as effective as the child catheter.
And I fully agree. I mean, no use the guideline for aspiration, because there is a space between the guide liner and the guiding catheter. So some of all the thrombus, even if it comes out, it doesn't get sucked out when you withdrawing or inadvertently injecting. That thrombus can get dislodged between the guide liner and the guiding catheter and go back in. That is more dangerous than good. Don't use a guide liner for thrombus aspiration. There is another question which came up. How frequently you should look at the ACT. Whether regarding the left main dissection or thrombus which you showed, my feeling is when you deal with any ostial LAD, be ready to cover the left main, the main stem or left main also, because it's very, very difficult unless you do an OCT to find out a dissection at proximal end of the stem. 99% the influence happen of the left main thrombus is by by the dissection of the ostium, which dissects backwards and thrombus collecting, and that would be the main cause of. That is my experience. So I would err towards stenting the left main than trying to place the stent exactly and trying to get away with it. Please be very careful. If you have got an OCT at the end of the procedure, then it's fine.
Sir, you must be having some experience with directly aspirating with the guide catheter itself, isn't it? I'm sure.
Yes, we have. Guiding catheter aspiration when the thrombus is the first case. You can advance the guiding catheter a little more in and have a 20 cc syringe and aspirate. Very often the thrombus will come off just like that. It is very, very useful. But be careful, be gentle. The guiding catheter, you shouldn't traumatize the vessel. I think we are running short of time. We will wind up now and we'll go on to the next. There are lots of questions coming up. But thank you, Natarajan, once again.
Thank you, sir. Thank you.
And I'm sure Sarvamuni will be the next person who will going to entertain all of us and teach us a lot of tricks on how to handle dissection.